I'd like to welcome all of you to the Many Faces of Colon Cancer. My name is Margaret Stauffer, and I'm going to be the MC this evening. We are so pleased to have a great panel of physicians and dietitian who are going to present a lot of information.
And our final speaker tonight is Tinrin, who is an oncology dietitian. And she's going to take the last 20 minutes of our conversation here to talk about nutritional aspects of colorectal cancer. And then we'll have about 30 minutes for the questions. If you have a question that you'd like Tinrin to ask, please use your pink card. Thank you.
Thank you, Margaret. Thank you so much for having me tonight. I know it's been, you've all been sitting here for 1 hour. Do you want to get up and stretch a little bit before our well sleep? So basically, what I would like to start is that usually when a patient comes to me, they will come to me, usually they said, okay, I'm getting the history report. I've seen my gastroenterologist diagnosed me with colorectal cancer. Then I had surgery. They cut. Now I'm going through chemotherapy under oncologist, or I'm going through concurrent chemoradiation. Now what do I do? That's one scenario. Another scenario, patient will say, I did all that, but I'm just pile of gas. I have such a terrible time with my bowel movement. I have no taste. What do I do? So this is my piece, not only to lead you through some of the things that we deal with while patients going through chemotherapy, radiation therapy, or just dealing with the treatment itself, but also what do we do in the long haul for cancer disease prevention. So the nutrition challenge is going through cancer treatment, not only just mouse score, because it has to do with 5 and few, as Dr. Joel mentioned. Gut irritation, that's one of the most common issues. Dry mouth, diarrhea, excessive gas, bloating, flatulence, lack of appetite, lack of taste, or taste alteration, as well as fatigue. All these things are the very common side effects cancer patients going through colorectal cancer treatment faces. But the interesting thing is that most of them also may come in with already underlying nutritional deficiencies to begin with. So what do we do about that? What I'd like to share with you just a few side effects management. What happened to the other side? And there are 2 parts. That's okay. We'll just do whatever we have. We're missing part, half the side of the slides. But anyway, what I'm going to share with you is some of the things I'll be sharing with you the next couple of slides will be not in your textbook, or I call it not in the books that you see from standard books, such as by American Cancer Societies or by National Cancer Institute. What I'm going to share with you are some of the recent studies or some of the things that we really see the practicalities patients experience by home remedies, I call it. So I would like to share with you nausea, for example. Besides the standard treatment modality as anti-nausea medication, since 2008, we know more the data that ginger seems to have a pretty good anti-nausea effect. So the study was done basically when people started getting chemotherapy, having ginger 3 times daily, whether through the ginger capsules or using ginger candy, ginger tea, or fresh ginger. Either way, it doesn't really matter, 3-4 times a day. Subsequently, another study came about. Ginger really did quite a bit of good things for nausea control in addition for anti-nausea medication. However, could we do something better? So high protein diet came about in addition to ginger. Was that when patients are sitting in the chemo chair, actually give them a high protein drink followed by high protein diet for the next 3 to 4 days. Has better anti-nausea control. Olden days, we used to give people high starchy foods, crackers, salting, bread, type of things. We call it pregnancy diet, right? Give them starchy things. But those starchy foods pretty much empty out the stomach within about 30 minutes to an hour. Patients come back nauseous again. So what we have found that giving them a high protein diet actually giving them a little bit more sustained anti-nausea effect. So currently in the oncology nutritional care, what we try to have patients do, besides just using anti-nausea medication, we instruct them to use ginger and some high protein diet. Diarrhea, again, still follow the tradition route of low fat, low fiber, lactose, low lactose diet, as well as small frequent meals, etc. Still follow the textbook, but a few things I want to highlight is that very often when people have diarrhea, we just tell them to drink lots of liquids, right? One of the problems, many people will say, well, they just told me to drink. I said, what do you drink? They usually say water. Wrong. One of the biggest things people make mistake is that electrolyte repletion. So whatever they drink, I usually tell them just have some diluted fruit juice or have some banana shakes or have coconut water, adding some salt, as long as the electrolytes. So some people like to use quote unquote Gatorade power drink, power shake, or NUUN as one of these sports drink that seems to work very well. Rice congee, we call basically chicken soup with rice. Probiotics is one of the things that we commonly use, not only to control the diarrhea, but also to reduce potential infection. So it's one of the things we commonly use is, you probably have heard a lot, typical classic probiotics, if it's not supplements. Most people recognize them as yogurt, as kefir, as a kimchi, all those things. But of course, during the diarrhea time, you won't be eating kimchi. Soluble fiber. The other thing is soluble fiber will be something like your banana or like your white bread, white rice. Those all contain soluble fiber. Definitely, we do use glutamine in the nutrition arena. Primarily, we know that nutrition is a very elemental amino acid that nourish the mucosal lining. So sometimes we may use glutamine, depends on situation. Especially glutamine, we do use it related to radiation or 5-FU related type of inflammation. And lastly, of course, food is room temperature. The other side of the slide, which we're missing, is sometimes people will say, geez, I really don't have taste. Everything just tastes awful. Very often, we may just put people on a short course of zinc supplement. Because if we look at some of the population, if they're a regular drinker, alcohol drinker, they have been on long-term any type of antacid, or they have been on multiple medication. Now they started with some drug called oxaliplatin. Sometimes they may be zinc deficient, or sometimes they may be iron deficient, creating that taste alteration as well as taste blindness. And so the other side of slides will be the taste. And lastly, I can't really remember exactly what I'm thinking of. Basically, I think it would be more probiotics and amino acids. Now for neuropathy is another very common seen side effect with oxaliplatin type of treatment. Generally, again, we use neuropathy research. We look at alpha-lipoic acid and acetylcarnitine, but of course, acupuncture, exercise, they all may help with neuropathy. So how do we maximize nutrition? Traditional approach, generally we tell people, 20 years ago, even 10 years ago, most people in the oncology care arena, whether it's physician, healthcare professionals, we just tell patients, go ahead, eat whatever you like to eat. It doesn't matter regardless what you eat. High fat, high sugar, high protein, just get through the treatment. And the classic diet, I call them, these are the standard American diets. Just get through your treatment. But is that really sound? Or we tell them to go with a low fiber diet. Is that really the right thing to do? It's still being debated. And we tell people just go ahead and rest. And second part of the slide we're missing, the other side. Instead of traditional approach, what currently we're doing, I call it paradigm shifting. Paradigm shifting basically means that we do use functional foods, the food that really is good for your body. We use phytonutrients instead of just eat a cheesecake or a glass milkshake or hamburger, cheesecake type of thing just to gain weight, high calories. Instead of talking about using high caloric foods, well, we're teaching our patients just not so much to use high calorie food, rather a balanced food intake. High protein, and we still use high protein, no doubt, but we do define specific type of protein. Sometimes we may go with a whey protein powder or very high biological protein. Sometimes we may even use specific amino acids, such I have alluded to, glutamine or arginine in different circumstances. High fat, instead of randomly just give the people high butter fat, high oil, well, we do try to use some of the good fats, particularly omega-3 fatty acids. So the list goes on. I apologize, and the other side is missing, but that's the logistics of it. What I like to highlight, if you go down the column, you see colorectal cancer. Basically, is that cancer could be prevented, as Dr. Zamani is saying, is that colorectal cancer from the dietary, nutrition, lifestyle pretty much contribute to colorectal cancer up to about 45%, as you can see the slide. What are some of the common risk factors, or we call it promoters, to promote that little polyps of atypical cell to continue to grow in the accelerated fashion? Generally, what we're looking at from the epidemiological study or solid research now, obesity, lack of physical activity, these are the most common contributing factor. Then we look at a high sugar diet. I don't believe the high carbo diet is a contributing factor, but rather a high sugar diet along with obesity, that becomes a little bit more deadly. And the other contributor will be your red meats, processed meats. Possible reason can be higher animal fats, higher iron, because when we don't require that excessive iron, high iron basically creates more oxidative tissue damage because of oxidation. And processed meats because nitrites and high fats. And so all these studies have pinpointed the red meats and processed meats. Actually, in the United States, when we look at the colorectal cancer, it's more with the red meats. But with European studies, the Germany study, we look at the sausage, which is your processed meats. And the lastly, promoters, of course, is the alcohol. So for somebody who comes to my door, say, hey, I have a very high family history of a colorectal cancer, one of the things I do want them to watch out, besides the first four, will be your alcohol intake. So this slide, I'm not sure if you'll be able to take a look at this, is pretty much summarize why we look at obesity, activities, and high simple sugar intake. Is that when we look at physical inactivity, abdominal fat, primarily is abdominal fat from the BMI, combined with your red meats and saturated fats and refined sugar, is that you increase that insulin resistance. Insulin resistance commonly seen in all overweight and obese population. So therefore, they create more the insulin secretion because insulin resistance pumps your pancreas to produce greater amounts of insulin. The problem with the insulin is that proper amount of insulin, we needed it. But when there's excess amount of insulin production in the presence of high abdominal fat content, is that it creates insulin overproduction. Because insulin overproduction, that it leads to what we call the hyperinsulinemia. As a result, produce another biological agent we call insulin growth factor 1. Okay, and with research we know with insulin growth factor 1 and excessive insulin production pretty much promote the cancer cell growth rate and reduce that programmed cancer kill. So with numerous data right now, we do know when colorectal cancer patients, if they continue to gain weight, similar data we see with the breast cancer, uterine cancer, prostate cancer, is that overweight pretty much leading to poor prognosis. At the same time, disease recurrence may just be much higher because increased tumor cell proliferation rate and decreased cancer kill rate. So on the good news is that what can we do as to protect ourselves?
Number one, of course, fruits and vegetables. I think it's not really a fun term to tell the American population to eat so much fruits and vegetables, because people just don't want to even talk to a dietitian. First thing, most of my patients walked in the door say, I just know what you're going to tell me. Eat more fruits and vegetables. I said, I'm not going to tell you what you need to eat, but I want to measure you to see how much you actually eat, because there's a really pretty interesting machine, which I won't talk about it here. Secondly, is to have a higher fiber diet. How much fiber should a person need? Pretty much about 25 to 35 grams, depending on your body size. Take a wild guess. How many grams of fiber does the average American population consume? Oh, a little bit better than that. 10? Yes, pretty much about 8 to 10 grams. Okay, so we're far from that. Why do we need whole grains of legume? Because for one simple reason, it helps us to continue to clean the bowel wall, and number two, to decrease the bacteria adherence to the bowel wall, and helps the toxin excretion. Another good colorectal cancer protection is your folic acid, particularly for the drinkers. Okay, the data is very interesting. Is that we don't see a further benefit of having folic acid supplementation if you are not folic deficient. However, if you're folic deficient, then there's definitely a benefit of supplementing with a folic acid, because folic acid, along with other B vitamins, as well as other nutrients, I do believe, even though the data has not come out yet, I do believe all these micronutrients, folic acid, B vitamins, basically controls your DNA transcription. When the folic acid is not there, pretty much you can make 1 billion copies. The cells just continue to go on and on as mistake transcription. Calcium and vitamin D, current data pretty much suggesting between 600 to 800 milligrams calcium daily gives you that extra protection. However, you do need to ensure you have adequate vitamin D intake. Statistically speaking, about 80 to 85% of colorectal cancer patient diagnosis that actually they're either vitamin D insufficient or vitamin D deficient. So as a general rule, I pretty much a lot of times I bother physicians, either primary care or oncologists, please take a vitamin D check on the patient just to see what it is. Because if you're vitamin D deficient, then we should correct that. But overall, if we don't do that testing, I feel everyone should be pretty much be covered with at least about 2,000 unit vitamin D supplementation. Omega-3 fatty acids, because it's good anti-inflammatory agent. Physical activity, I don't have to elaborate again, but I just want you to know ever since 2006 data came out, I really appreciate a lot of great oncologists pushing their patients to exercise. The data basically came out was that by exercising, even stage 3, stage 4 colorectal cancer patients' survival rate is 40 to 50% than those people who do not exercise. So the data is astounding. What are we talking about the long haul for long term? Keep a healthy body weight, keep your BMI at least below 28. Okay. The normal BMI is 19 to 25. When you go below 19, it really is not that good because you don't have enough reserve. But when you go beyond 26, 28, you start seeing the risks start climbing. Number 2, be physically active. I'm just going down the line from the priority sense point of view based on the data. Be physically active. Exercise at least 30 to 45 minutes daily, whether it's brisk walking or do some type of small jogging will be great. Number 3, predominantly a plant-based diet. I would like for you to kind of visualize with me a plate. Half your plate will be all your vegetables and some of the fruit in that plate. And then quarter of your plate will be something of your just a small amount of chicken or meat. And the other quarter part will be a whole grain, whether it will be quinoa or some kind of wild brown rice. That will be your ideal diet, all right? Plenty fruits and vegetables, whole grain legumes, so on and so forth, and low fat only pick the healthy fat, not so much like a whole huge T-bone steak. Not saying that you cannot have T-bone steak, but I do tell my patient, yes, if you really want a T-bone steak, trim the fat, limit to just about 6 to 8 ounces, then that's fine. Limit your energy-dense foods, such as your dessert items, as well as beverages. Drink plenty of fluids. That's another thing. Data doesn't really say that, but I really do believe that green tea, because there's so many different studies that have shown the benefit of green tea in reducing gastrointestinal type of cancer. And lastly, alcohol. When you drink alcohol, once it comes with the diagnosis with cancer, I tend to be a little bit more conservative now. For women, I tell women about one drink a day, limit to no more than 3 times per week. I tell men about limited 2 drinks per day, no more than 3 to 4 times per week, pretty much. And actually, there's some newer recent research shows that greater amount of alcohol drink actually increase the cancer-related mortality rate. Related not because of alcohol, because alcohol contributing to the cancer itself related death rate. And lastly, adequate vitamin D and high quality of some type of supplement, multivitamins and minerals if you are not eating adequately. So generally give you a beautiful picture here. This is what I'm looking for my patient's diet. Lots colors. Fruits and vegetables, eating at least 1 to 2 different vegetables at one time, because synergistic effect. Number 2, use lots of spices and herbs, and use good fats, olive oil, avocado, seeds and nuts, and different types of spice, herbs, salsa. I love it. So use them for your dipping, use them as your marinade to include them in your diet for your long-haul, long-term survivorship. Thank you so much. I think that's it.